without incision to the original bulb, just to cover it with the free flap conjunctiva. The flap was sutured with absorbable bicules. After the surgery, the shape of the bulb is unchanged. No bulb leakage is observed. This was a more severe case. 76-year male POH patient. When he was 60 years old, both his eyes were treated with strap. He encountered ocular injury after surgery. The bulb wall was lost. The sclera was bare. The eye was associated with flat anterior chamber and coronary endothelial damage. In the treatment for such severe cases, I perform amnion membrane transplantation, which is supplied by the tissue bank. After removal of the inferior conjunctiva, the bulb was covered with the free flap conjunctiva. Then the conjunctiva was covered with the amnion membrane. After trimming the membrane, it was sutured with absorbable bicules. After conjunctival and amnion transplantation, no bulb leakage was observed, and the anterior chamber was recovered. IOP is stable between 7 and 12 mmHg in 4 years after surgery. I performed conjunctival autotransplantation in 5 cases. Bulb leakage stopped in all the cases. This slide shows IOPs. All the patients encountered hypotony when bulb leakage occurred. After the conjunctival autotransplantation, IOPs recovered around 10 mmHg. This technique is also effective for the coverage of exposed silicone end plate after the valvular glaucoma implantation. Take-home messages. Avascular dysfunction bulb is a good indication for bulb needling because the needle easily approaches to the scleral flap. The eye with a thick scarring bulb should be reoperated with the tube shunt surgery with a valvular glaucoma implant. Conjunctival autotransplantation is very simple but effective for treating the bulb leakage. Thank you for attention.
It's a pleasure to be here today to speak about malignant glaucoma. I have no financial disclosures related to this presentation. Malignant glaucoma was first described by von Graefe in 1909, and he called it malignant because of its unrelenting course, often unresponsive to therapy. It is a secondary angle closure glaucoma with a posterior pushing mechanism. It usually occurs after incisional surgery, most commonly glaucoma surgery, but can also occur after cataract surgery or after laser procedures. It can develop with a wound leak or with withdrawal of cycloplegics, and it can even develop intraoperatively or with the institution of miotics. The most common risk factor is high hyperopia and chronic angle closure glaucoma or narrow angles. It can occur in phakic, pseudophakic, or aphakic eyes, and can sometimes even occur spontaneously or after trauma. The mechanism is a little controversial. A precipitating event usually leads to aqueous being directed posteriorly, which compresses the anterior vitreous, making it impermeable and acting as a barrier for the movement of aqueous forward. There develops positive vitreous pressure, which shifts the lens iris diaphragm forward, causing shallowing or flattening of the central anterior chamber, angle closure, and elevated pressure. It is thought that many other factors may contribute. Chandler and Grant described loose zonules as causing the propensity for forward movement of the lens iris diaphragm. Trope described ciliary lenticular block and identified this on ultrasound. Quigley feels that the precipitating event is choroidal expansion, and there's also a factor of an impermeable anterior hyaloid. In a study of 58 eyes, the majority of eyes had anterior rotation of the ciliary processes and 10% had a choroidal effusion. Thankfully, it is uncommon. The TVT trial of trabeculectomy tube versus trabeculectomy of 242 patients found that only 3% of people in the tube group had malignant glaucoma, and as opposed to 1% in the trabeculectomy group. The key to recognizing malignant glaucoma is the central shallowing of the anterior chamber from this forward displacement of the lens iris diaphragm. And this is differentiated from pupil block, which has shallowing peripherally but not centrally. And the posterior segment is normal in malignant glaucoma. Patients typically present with pain, elevated pressure, shallow or flat anterior chamber. Pressure is typically high, but not always. There can be relative aqueous misdirection where the anterior chamber is shallow, but not flat, and the angle is not fully closed. You could also have relative aqueous misdirection with a functioning filtering bleb. UBMs will show an anterior rotation of the ciliary body and forward displacement of the lens iris diaphragm. And we can see here the resolution of that forward shift after vitrectomy. A patient I had just this week was a 60-year-old man with hyperopia, more so in the right than in the left eye, who had LPIs at age 50. We planned cataract surgery with goniosynechiolysis. Left eye was performed first. We placed a 28 diopter lens, gave him atropine in the OR because of his high risk, and he had an uncomplicated postoperative course with a minus 0.25 post-op refraction. His right eye was performed a couple of weeks later. We placed a plus 31 diopter lens. We didn't have atropine available in the operating room. Additional cyclogel was given at the end of surgery. And he came in post-op day 1 saying, "Doc, my eye feels fine and I can read great, but everything else out there in the distance is blurry." And he had a minus 2.5 diopter refractive surprise. His pupil was dilated, his anterior chamber was flat peripherally. It was formed centrally, but clearly shallower than his other eye. His pressure was 10, his fundus was normal, no woundly, and he had classic relative malignant glaucoma. We treated him with atropine and aqueous suppressants, and post-op day 2, he said everything's getting clearer. He was a minus 1, and his anterior chamber was deeper, still not normal, but much deeper and only slightly shallower than the left eye. So medical management is the first step for the treatment of malignant glaucoma. Cycloplegia is the hallmark, atropine, home atropine, and people may need it permanently. Aqueous suppressants are very important. Hyperosmotics may be given to decrease the vitreous volume, and be sure the patient is not taking miotics. Laser treatment may then be required. An iridotomy is usually performed if there's one not already present, just to be sure there's not a component of pupil block. Then a YAG laser can be used to disrupt the anterior hyaloid face and the anterior vitreous. It can be performed centrally in pseudophakic patients or through an iridotomy in phakic patients. In this study of 10 pseudophakic eyes with malignant glaucoma, they had resolution in 7 out of 10 eyes when they treated with an iridotomy and went through the iridotomy and affected the capsule and broke through the hyaloid inferiorly. And they postulate that inferior laser may be better at reaching pockets of aqueous. Surgical management is going to be required in at least 50% of cases. The goal is to create a unicameral eye. You need to make a connection from the anterior chamber through the vitreous cavity, remove all the vitreous, and perform an iridozonular hyaloidotomy. In that study, again, of 58 eyes, they had success in all 43 patients in who they created a direct connection from the anterior chamber to the vitreous cavity. Please remember in high-risk eyes and in fellow eyes to discontinue miotic drops. If you operate on them for cataracts, do not use a miotic at the end of your surgery, and treat them with atropine prophylactically. Try to avoid shallowing during the surgery as well. You can develop aqueous misdirection and malignant glaucoma during surgery. You may have already experienced this. There may be a sudden increase in intraocular pressure with shallowing of the anterior chamber. There may be iris prolapse. Try treating with topical atropine and IV mannitol, and try to wait a little while. It's very hard to wait in the middle of surgery. A small core pars plana vitrectomy can be performed, and you can also decompress with a 25 gauge needle if needed through the pars plana. The key takeaways in malignant glaucoma, there is anterior displacement of both the iris and the lens that cause axial shallowing and central shallowing of the anterior chamber. And this is distinguished from pupil block, where there's only peripheral shallowing from the iris bombée and the central chamber stays deep. The treatment as cycloplegics, more cycloplegics, and if that doesn't work, laser. And the goal of surgical treatment then is to create a unicameral eye with communication between the anterior chamber and the vitreous cavity. Thank you so very much. It's been a pleasure.
So the title of my lecture is Bleb dysesthesia. The objectives of this lecture is to define Bleb dysesthesia, to describe the symptoms, the risk factors, and the pathophysiology of this condition, and to describe the multiple therapeutic, conservative, and surgical approaches that exist. So when it comes to the definition, Bleb dysesthesia is an uncommon complication of glaucoma filtration surgery, in which a well-functioning but large filtering bleb with adequate IOP control causes ocular discomfort due to the effect of interrupted tear film distribution over the bleb and cornea. So what are the symptoms that patients most frequently complain of? Pain, tearing, ocular discomfort in general, foreign body sensation, and sometimes reduced visual acuity. The risks of this condition, even though they rarely happen, is for the patient to develop adelin with ulceration and perforation, rarely bleb ruptures or infections like endophthalmitis. So what are the risk factors? What patients and what bleb characteristics increase the risk of having this problem? Well, young age is associated with this, supranasal location of the bleb, the use of antimetabolites with a secondary abnormal vascularization, bleb overhanging on the cornea or extension towards the cornea, excessive extension of the bleb itself, steep walled excessive height of the bleb, and or circumferential blebs, intrapalpebral exposition of the bleb, poor eyelid coverage, sometimes because of eyelid retraction, with or without steep walled blebs causing bubble formation. So when it comes to the pathophysiology, it's not fully elucidated, but two potential mechanisms have been described. On one side, a hypocellular tissue response, probably related to the use of antimetabolites, creating an avascular bleb that then reaches a larger size. Connective tissue hypertrophy caused by an extensive scarring reaction in a susceptible eye, contributing to the bleb height. So when it comes to conservative management, we usually use aggressive lubrication with drops, ointments, topical NSAIDs to diminish discomfort, inflammation, pain, pressure patching, oversized bandage contact lenses. This usually only helps in very mild cases. When it comes to surgical management, we have less invasive approaches and more invasive approaches. The less invasive approaches like autologous blood injection, application of trichloroacetic acid, or cryotherapy or argon laser therapy are usually less effective and sometimes prone to filtration failure, or you have to repeat them in multiple sessions. When it comes to surgical approaches, surgical reduction are usually indicated for highly symptomatic blebs, and it's usually the only effective treatment. And the success rate, meaning keeping the bleb functioning without the use of drops, has ranged between 43% and 100%. depending on the technique used. Entire bleb excision with closing of the fistula with a scleral patch graft, for example, an insertion of a drainage device, is probably the most extreme approach, the final approach. Sometimes partial excision of the affected bleb with advancement of conjunctiva and tenons can be done. Partial or entire bleb excision with advancement of the conjunctiva and tenons. But this tend to have worse surgical results when it comes to how good the bleb works down the road. And it's really counterproductive due to excessive elimination of conjunctival tissue that actually it's working properly for IOP reduction. And there is always risk for leaks in this kind of approach. But it may be the only option you have depending on the characteristic of your particular case. There are also techniques that preserve bleb conjunctiva, limitation of bleb size without removing conjunctival tissue. For example, compression sutures with or without autologous blood injection can be used. Bleb window cryopaxy, bleb limiting conjunctivoplasty with or without excision of subjacent subconjunctival tissue when identifiable, and surgical bleb reduction. This is an example of compression sutures. The surgeon usually anchors one or more nylon mattress sutures to the cornea, passes them posteriorly over the portion of the bleb that you're supposed to compress, secures the suture with an episcleral bite, and then passes back over the bleb anteriorly. Then he or she ties the knot and rotates it into the cornea in a shoelace or mattress pattern. The sutures should be fairly tight to ensure that the overlying bleb is well compressed and they remain in place for 1 to 4 weeks. This can be done with multiple sutures, multiple passes like we see on this, picture on the right inferior side. Another example is the bleb windowpaxy technique. There is a conjunctival window created to bear sclera in the interpalpebral area. Color is applied to achieve hemostasis, and then you can either use fibrin tissue to secure the conjunctiva to the sclera, or you can use just sutures to do that. And by doing this, this is usually how you treat circumferential extension of blebs. By just cutting the flow, you will limit the bleb inferiorly. This is similar, a case where you have an inferior bleb by doing this conjunctivoplasty in the interpalpebral area. You will most likely be able to cut the flow that feeds the inferior part of the bleb. So in conclusion, bleb dysesthesia is an uncommon complication that very likely needs surgery due to failure of medical treatment. Aggressive surgical techniques removing bleb tissue may be less effective in terms of subsequent IOP control, although in specific cases they are necessary. Techniques that preserve bleb conjunctiva show the possibility of excellent success in correcting the dysesthesia while preserving the filtering function. Several techniques to preserve bleb conjunctiva exist and should be tailored to the particular case. Thank you.
Hi, ladies and gentlemen. I'm Catherine Liu. It's my pleasure to give the talk, Bleb-related infection following trabeculectomy. Trab is the gold standard of glaucoma surgery because it could reduce the pressure down to low teens, but it's also accompanied by bleb-related infection. I have none to disclose pertaining to this presentation. BRI may occur within the first month of surgery, like any other operations, but there is a lifelong threat of infection with late onset BRI more common than early BRI. When we see cases with conjunctival injection, mucopurine material in or around the BRAP, often with several reactions in the anterior chamber, is BRI. BRAP-related endophthalmitis refers to cases with additional findings of hypopyon or cells and exudate in the vitreous body. BRE often presents with higher IOP and worse visual acuity, and outcome is often poor. The CBIS classified BRI into 3 stages. Stage 1 denotes infection confined to the BRAP. Stage 2 with anterior chamber as the main locus of infection, and stage 3 denotes vitreous involvement. Since the course may evolve rapidly from stage 1 to 3, it's crucial to keep alert about the danger of BRI in eyes with history of trabeculectomy and not to make misdiagnosis as viral conjunctivitis. One survey from Japan found that after resolution of infection, the visual acuity was 0.5 or better in eyes with stage 1 disease in 96% of the eyes, while around 40% of the eyes had visual acuity of 0.04 or worse. The workup required immediate conjunctival swab, stents, and cultures. Anterior chamber or vitreous tab may be required. Unfortunately, negative cultures are encountered in 21 to 86% of cases. Real-time PCR can increase the detection of infective organisms, but its widespread use is limited due to high cost and the possibility of false positive or negative. The common causing pathogens include Staphylococcus aureus and Streptococcus species, and less virulent Corynebacterium and Enterococcus. Treatment using broad-spectrum antibiotics should be initiated promptly before culture results become available, and it should comprise a combined therapy of topical, subconj, or even intravitreous or systemic antibiotics. Whatever the drug of choice is, loading dose of topical antibiotics is required to achieve therapeutic concentration. Vitrectomy is often suggested for eyes with apparent involvement. The incidence of BRI varies across different reports. Based on data from a few prospective studies, the cumulative incidence of BRI is around 1.5 to 3%, 5 to 8 years after trabeculectomy. The use of intraoperative supplement antimetabolites, inferior BRAP position, leaking BRAP, avascular BRAP are risk factors commonly identified. Other risk factors include contact lens wear and ocular surface disease, etc. For about 20 years, some researchers have reported that limbus-based conjunctival BRAP is more likely to evolve to cystic BRAP as compared to phonics-based BRAP, and the cumulative incidence of later onset BRI has decreased after they change from the limbus-based to phonics-based conjunctival BRAP. However, researchers from Japan found no difference in the incidence of infection between these two types of approach. It's encouraging to note that the cumulative incidence of BRI has decreased from 5.7% in the cohort from 1993 to 97 to 1.2% in the cohort from 1999 to 2005. Factors contributing to the change in BR incidence may include evolving experience in using MMC and the refinement of surgical technique over time, such as application of MMC over a wider area of the scleron, modification in the suturing of the scleral flap, changing the technique of conjunctival flap creation, and abandoning the inferior position trap. So based on the knowledge and experience we accumulated over decades, we now choose the optimal concentration of MMC case by case and create a trap with a diffuse spread, which facilitates posterior drainage of aqueous humor. In addition, take care of ocular surface disease, meibomian membrane dysfunction, and avoid contact lens wear and swimming are also important. As time goes by, watch the change in breve morphology diligently. Wound modification is a lifelong process, and the fibrosis may eventually heal the sclera. Right now, I prefer to do digital massage on eyes with a functional breve by using cotton tip applicators at each follow-up visit, attempting to maintain a patent fistula by deterring scar tissue formation so that it will not eventually demarcate the breve. When we see a breve which is leaking or sweating, we should do something about it. Breve revision using a needle or breve knife can convert a high cystic breve into a low diffuse breve with good IOP control. Prophylactic topical antibiotic is effective in suppressing early onset BRI, but intermittent or chronic use of topical antibiotic is strongly related to an increased risk of late onset BRI. So this strategy should be discouraged. It is also very important to inform patients or their caregivers about the significance of red eye, mucopurulent discharge, and decreased vision, and tell them to seek help immediately. In summary, BRI may have vision-threatening consequences, so it's crucial to keep alert about the danger of infection in eyes with history of trabeculectomy on the part of both patients and physicians. Early detection, immediate workup, and prompt and intensive treatment are the keys to success in preserving patients' vision. Thank you very much for your attention.